Good morning, everybody. I am Dr. Omar Awwad. I am a professor of cardiology at Ain Shams University. We'll be discussing together a very important topic about the prevention of hypertension. According to the Framingham study, the residual lifetime risk for incidence of hypertension is about 90% on those individuals from age 55 to 65 years of old. And the lifetime risk for those individuals to take antihypertensive medication is about 60%. And this incidence is higher, about 60% higher in female than male. And again, according to the GNC, about 23 million adults had high normal blood pressure, and another 38 million had normal but above optimum blood pressure. And actually, those individuals should be our target if we want to do prevention of hypertension. And since all the guidelines are stressing about the stage of pre-hypertension, on those patients, the attempts to prevent is very fruitful. What are the strategies for prevention? Actually, we have two strategies for prevention. Either the population-based approach, in which we are aiming to reduce blood pressure in the whole population. And based on the result again of Framingham Heart study, every 2 millimeter mercury reduction in the level of the blood pressure, we are going to reduce the prevalence of hypertension by 17%, the risk of stroke by 14%, and the risk of coronary artery disease by 6%. And some examples of the population-based strategy is reduction of the sodium content in processed food and providing safe, convenient opportunities for exercise for the whole population. The second approach is an individual target approach. And in this approach, we are aiming to prevent hypertension on those individuals whom are very liable to develop hypertension. Which are those individuals? Those are persons with pre-hypertension, family history of hypertension, African American ethnicity, patients whom are overweight, consuming a lot of sodium and alcohol, and living a sedentary life. And the different approaches to reduce, which is the lifestyle modifications for those population, is decrease the intake of dietary sodium, increase potassium supplementation, reduction of weight, moderation of alcohol intake for those whom are taking alcohol, increasing physical exercise, and modification of the eating pattern. And now we are going to discuss each item of these very important lifestyle modifications separately. As regards weight loss, there is an important trial, which is a trial of hypertension prevention, telling us that for every 1 kilogram reduction in body weight, we are able to reduce the systolic pressure by about 2 millimeter mercury. And very important that the weight loss intervention produce a benefit which is long-lasting. In this study, after 7 years of follow-up, the incidence of hypertension was 18 on the interventional group and 40% in the control group, whether they continue for the weight reduction intervention or not. So it is a long-lasting effect. As regards the increasing in the physical activity, there is an important meta-analysis which tells us that a regular aerobic exercise is able to reduce the systolic blood pressure by about 4 millimeter mercury compared with control group. And for that, there is an actual recommendation for every individual to exercise at least 30 minutes most of the days of the week. For modification of whole diet, there is what's called DASH diet, which is rich in fruits, vegetables, low-fat dairy products, and reduction in saturated fat. This DASH diet actually can reduce the systolic pressure by about 3.5 millimeter mercury, even among normotensive individuals. And there is another diet which is called DASH sodium diet, in which the excretion of sodium in the urine is less than 67 millimole per day, and this DASH sodium diet is able to reduce the systolic blood pressure by 7.1 millimeter mercury. And the beneficial effect of DASH sodium diet occur in all major subgroups. Moderation of alcohol, there is a linear relation between alcohol consumption and increase in the blood pressure, and the relation is dose dependent. The recommendation is not to exceed 30 to 60 milliethanol in male and not more than 15 milli in females. As regards dietary sodium reduction, which is a very important parameter in the prevention, the National Health and Nutrition Examination Survey telling us that 1 gram higher level of sodium intake is liable to increase the stroke incidence by 15% and the coronary artery disease mortality by 20%. Sodium even is stronger predictor of mortality in men whom are overweight. The current national recommendation for sodium intake is moderate low sodium, less than 2.4 gram of sodium per day, which is equivalent to 6 gram of table salt per day. For reduction, every 1 gram reduction of sodium intake is liable to decrease the systolic blood pressure by 2 millimeter mercury. And the DASH sodium trial telling us again that reduction of sodium intake from high to lower level is liable to decrease systolic pressure by about 4.6 millimeter mercury. Potassium supplementation is another measure to reduce the blood pressure, and potassium supplementation can reduce the blood pressure in hypertensive and normotensive individuals. And the effect of potassium supplementation is greater in those with higher level of sodium intake. Potassium supplementation, each 1 gram of potassium in diet can decrease the systolic pressure by about 1 millimeter mercury, and our daily requirement of potassium is about 2 to 3 grams per day. Other measures, which is less important in the lifestyle modification, is calcium supplementation. And calcium supplementation results in only small reduction of the blood pressure, and the effect is only observed on hypertensive individuals. And the calcium intake is recommended for healthy diet, and requirement is between 1 and 2 grams per day. Fish oil supplementation is another important parameter, and the high dose of omega-3 can reduce the blood pressure in hypertensive patients. 3.4 grams per day of omega-3 can reduce the diastolic blood pressure by 1.5 millimeter mercury. There is some adverse effects which include erection and fishy test, and not only this omega-3 can reduce the incidence of hypertension, but it also can reduce the risk of coronary artery disease and stroke. When we come to the herbal dietary supplements, there are marked and considerable increase in the use of herbal products all over the world. And herbal dietary supplementation, unfortunately, do not undergo stringent regulatory approval, and there is only few clinical trials which are available to support the use of herbal supplementation. And healthcare professionals, very important that they should ask about the use of herbal products for possibility of herbal drug interaction. And lastly, as regards the quitting of smoking, smoking does not increase the blood pressure in the long term. It can increase it momentarily after taking cigarette, but more importantly, it can injure the blood vessels and cause hardening of the arteries, and quitting smoking decreases the risk of having heart attack. Then, what are the implications which can be applied in the national, international level to apply these ways of prevention of hypertension? Actually, I have a great opportunity to alter the direction and dimension of global cardiovascular disease epidemic through policy intervention at the local, national, and global levels. As regards the local and national levels, only by dietary changes, Poland was very successful in reducing the risk of cardiovascular disease. These policies must be addressed directly and decisively. And this is actually can be done by educational for the public and also by regulatory measures. These regulatory measures can act through either price or non-price mechanism. In the developed countries, these measures are just influenced by using advice of the usual diet patterns. But when we take a developing country like Mauritius, they were very successful in reducing the cardiovascular risk only by community education and very importantly by regular intervention related to the price of edible oil. Again, measures to influence the quality of dietary fats should instruct elimination of trans fat and decrease of saturated fat from the daily diet. It's very important that government work with the food industry for the production, processing, pricing, and labeling of food products so that these goals can be met. Consumer education is very important to be informed for choice of the proper diet the individuals are taking. And we should know that markets are not autonomous entities and should be modulated for the public good either by consumer education or by enlightened regulatory measures. When we come to the global policies, which is very important, this can be applied by increasing the availability and utilization of vegetable oil in developing countries. Other very important parameter is genetic modification of crops for attaining an optimal fatty acid ratio. The production, preservation, and processing and distribution of fresh fruit and vegetables should be fair through an agricultural and trade policies. And lastly, reducing salt consumption should be done through intervention with fat manufacturing and labeling of the market food products. It's very important to take in consideration the bad effect of globalization, in which it can lead to extensive diversion of fruit from domestic to export markets. And again, we have to pay attention to the policy we are facing now and the consequence of selling fishing rights in the poor country. Lastly, the fast food industry and the rapid penetration of high salt, high saturated fatty acids, and high energy processed food has its deleterious effect, and we have to abort that. It's very important to have a national and international guidelines for health and for dietary advice. And these guidelines should stress the role of diet in primary and secondary prevention. And dietary advice should not be considered as a complementary or for pharmacological prescription, but it has its effective pathway by its own level. Health professionals must be trained to comprehend and communicate daily advice through counseling contact with individuals and groups. And lastly, the food-based dietary guideline, very importantly, to be taken into consideration the national context. Such protective policy program need to be brought on the national and global health agenda, and it requires a partnership between the public and private sector. Again, participation of the voluntary sector is to be considered. WHO and FAO are best positioned to inform and modulate such global and national action. What are the barriers? What are the barriers we are facing when we are trying to do prevention of hypertension and applying a healthy attitude of the individuals? These barriers, number one, the cultural norms. For example, some of the third world countries are considering to be obese is a sign of beauty. In order to change the concepts of the individuals, it needs a lot of educational procedures. Again, there is no attention to the value of health education in the different countries, and there is a lack of referral to registered dietitian. Economic disincentive is very important issue. What we mean by economic disincentive, that, for example, the low sodium diet can be with a higher price and the lower unit pricing of a larger portion. So we are not encouraging individuals to apply the right policy. And lastly, the lack of reimbursement for hypertension prevention counseling by third-party payers. This is a very important, because if we are not reimbursing the individuals, they will not go to take this very important advice. To overcome these barriers, there are two very important steps. Number one, the professional association with the policy developer should work with the food industry to increase the availability of lower sodium food products. Again, a very important attention to health education, which can be given through healthcare providers, school systems, public health, and voluntary association, which is very important. And lastly, to conclude, hypertension is an important preventable risk factor for cardiovascular disease, and it is the leading cause of mortality in the United States of America. To achieve the healthy people goal of decreasing the proportion of adults with hypertension from 28% nowadays to 16% all over the world, concerted effort should be directed toward primary prevention strategies. Lifestyle modification decrease the incidence of hypertension and should be recommended for all persons, especially those with pre-hypertension. And lastly, the timely adoption of prevention strategies decrease the incidence of hypertension and its subsequent complication in the general population, and it may interrupt the costly cycle of hypertension, and it may prevent the reduction in quality of life associated with this chronic disease. Lastly, you have to remember to eat a quarter less, to walk a mile a day, and never to smoke. And thank you very much.